Well, good afternoon, everyone, and welcome to this afternoon's breakout session on assessing safety culture and well-being. My name is Carty. I'm the System AVP for Patient Safety at Inova Health System, and I had the pleasure of serving on this year's Safety Summit Planning Committee. I'm very pleased to introduce our speaker, Jim Carty, and let me tell you a little bit about Jim before he starts his presentation. He is currently part of the Quality and Patient Safety team at Valley Health System and serves as the System Director for Quality, Strategy, and Coordination, where he works to align and coordinate system-wide organizational change efforts across various teams. Prior to this role, Jim led Valley Health's process improvement journey for the last 9 years as the System Director for Management Engineering. He also has previous experience as the Director of Performance Engineering in Premier's Performance Partners practice and served as a senior consultant in GE's Healthcare Performance Solutions business, where he focused on designing efficient and patient-centric hospital workflow. Jim began his career as a manager and Six Sigma Black Belt at one of GE Lighting's high-volume manufacturing plants. He is also a retired officer of the U.S. Navy Reserve, a graduate of Lehigh University with a Bachelor of Science in Chemical Engineering, and an MBA from Shenandoah University. We may have time at the end of this session for a few questions, so please feel free to use the chat box to raise your questions, and we will try to get to those. So with that, please join me in welcoming Jim.
Thanks, Carty. Let me just share my screen here. Okay. Well, good afternoon, everyone. As Carty said, my name is Jim Carty, and I'm part of the Quality and Patient Safety team here at Valley Health System. And I want to thank you for joining me today to talk about one way to assess safety culture and well-being in your organization. Along with that, I'll share with you some results related to steps that we've taken here at Valley Health to improve our safety culture, well-being, and especially during COVID, our resilience. And let's see, this did not. Slide is not advancing. Okay, that was very strange, but does anybody know who this gentleman is? This is William Thomson, also known as Lord Kelvin. Yeah, the person with the temperature scale for absolute zero named after him. He was a pretty big deal in the 19th century scientific community. His big deal now is that he's got some great quotes for 21st century PowerPoint presentations. Two of my favorite ones underscore the need to be able to measure something in order to understand it and improve it. And that can also often be hard with something like culture, which is why we're so excited about the success that we've had measuring it at Valley Health. And just to show that nobody is perfect, not even the eminent Lord Kelvin, he did have one miss that I assume he probably wishes he could take back. And x-rays, yes, they are real. So first, I want to talk about where culture fits in. I've tossed around the words on this pyramid for years, but I could never remember where I actually first saw it. So this presentation was actually the perfect chance for me to figure out that, I really need to give credit where credit is due. So I did a Google search. And simply enough, it turns out it's called the results pyramid. It's from two authors, Roger Connors and Tom Smith, from about 20 years ago. So I went to their website and they had an article there about working with Inova. So that is probably where I learned it, from one of our fellow Virginia health systems. So thank you, Inova, for teaching me this. The short version is, a lot of times we keep trying to change our outcomes just by changing what people do, their actions. But in reality, just as outcomes are the result of those actions, Those actions are in turn the results of beliefs, and the beliefs are the result of what people experience in their environment or their culture. If you're trying to reduce errors in the OR, you can tell people to speak up, but if they see something that doesn't speak up, if they see something that doesn't seem right, but will they? And it all depends on their past experiences in the OR. If they've tried to speak up in the past and got shot down or ignored, then their belief is that they'll get shot down again. They won't act to speak up, and the outcome is that our patients will suffer. Now, conversely, if the culture in the OR makes it safe, easy, and worthwhile to speak up, that experience will let people believe that their voice will be heard. Their action is that they will speak up, and the outcome is our patients will benefit. Now, this isn't just limited to speaking up in the OR or even just to healthcare in general. If you think about it, these 4 steps, you can really apply them to just about anything in life, which is why I love these, and I've just tossed them around for years. So rather than just measuring actions, we realized that we needed to move down to the base of the pyramid and assess our culture. So since 2019, we've been using the SCORE survey from Safe and Reliable. It was developed by them in conjunction with Brian Sexton, who we heard from earlier today. We've been using it as our annual safety culture measure at Valley Health. In 2021, our survey, which I'm showing the summary view here, was the SCOR, no E on the end, since we had already measured E engagement separately through Press Ganey. The results are broken into 8 cultural domains: improvement readiness, local leadership, burnout climate, personal burnout, emotional thriving, emotional recovery, also known as resilience, teamwork, and safety climate. The first couple of slides that I'm going to be showing you, they're going to have a lot of small print on it, and that's fine. The intent of those slides is not to go through all the detailed results. That would take me hours, and I don't think anybody wants to spend hours looking at our results, but rather just to orient you to the survey and provide some context for the specific results that I will share. The summary report that I've shown here provides a great overview: response rate, percent positive, percentile rank by each cultural domain, year-over-year comparison, one-year summary of notable insights and key drivers, and a breakdown for each question of the survey. And now, while that summary is great, the real strength comes in being able to stratify and really dig into the data. I've been working with the survey for 3 years, and I'm still finding new ways to dig in and gather additional insights. First, each of the 8 domains can be sliced. For example, here I have the teamwork domain sliced first by our 9 entities, then by position type, like you saw in Dr. Sexton's slides on emotional exhaustion, and then again by work unit at any one of the entities. And what it shows is that culture is local. Overall, across Valley Health, again, just using the teamwork domain as an example, it rolled up as 44% positive. But then you look at the 9 entities, and that varies 37 to 65%. Position level, 25 to 81%. When you look at the local work unit level, 6 to 87% positive. So huge differences. The 87% positive unit is very different from the 6% positive unit. And that tells me we need to understand each local culture, and we need to understand what specifically within the teamwork domain is driving those different results. So let's take a look within the teamwork domain and the questions within it. And again, you can see across the question levels, the percent positive varies with each individual question. And just picking one of them, dealing with difficult colleagues is consistently part of my job. Wonder how we all answer that, but we can again see that there's significant variation by position, entity, and not shown here, but local work unit as well. Now, the importance of that, the importance of having to deal with difficult colleagues, it becomes clear when you start comparing it to other domains or questions. For example, there's a strong correlation between dealing with difficult colleagues and emotional recovery, also known as resilience. Those people who frequently have to deal with difficult colleagues are the same people who are less able to recover from emotional challenges. Similarly, we can use the score survey scatter plots to look at some of the questions in the local leadership domain. Things like local leaders are available at predictable times, correlating with emotional recovery, or local leaders providing positive feedback correlates strongly with safety climate. Now, I am not saying cause and effect, but understanding the correlations has helped us to identify actions that align with one measure to see if they also impact another measure. For example, it's a whole lot easier to identify an action aligned with leaders being available at predictable times, or leaders providing positive feedback, than it is to identify an action that directly impacts emotional recovery or safety climate. So now you're probably asking, all right, so what'd you do? Leader rounding. All right, several years ago, we established a no meeting zone block of time each morning to allow local leaders to be present in their work areas. It was okay, but what it was missing was the senior leaders. One of the first things we identified in our work with Safe and Reliable and our 2019 survey was the need for senior leaders to also spend more time in the frontline work areas. And I will be the first to admit that it wasn't easy at first, and it took time for people to get used to it. Some local leaders were nervous about what issues might come up or what staff might say to the senior leaders, which sometimes led to a whole entourage of the senior leader, the local leader's manager, the local leader's director, all tagging along because nobody wanted to be caught out of the loop. And obviously that's not the right thing, going and trying to talk to frontline staff when you have, 6 people all in a gaggle. And then some people were still stuck in the mindset that the only reason why a senior leader would be coming to their work area was that it meant something bad was about to happen. And so they would try to avoid the leader. Something bad is coming. I'm going to not be available right now. And then some leaders, they were really eager to jump in and, solve problems and save the day. But, unfortunately, that unintentionally undermines the local leader. So we had to be very careful to make sure everyone understood the why and the how of the rounding. Above all, the intent was to build understanding and trust. Leaders needed to understand the work being done, the daily challenges being faced, and the great work being done by the frontline staff. As Dr. Bundy mentioned earlier, this is by being better listeners. Or, as our Quality and Patient Safety Officer, Dr. Estrepo, has explained to our leaders, big ears, big eyes, little mouth. The staff needed to see that understanding and trust of the leaders, that the leaders cared about and valued the work being done. Once we have the understanding and trust, we're starting down the road to psychological safety, where people become able and comfortable raising issues and questioning things that they don't understand. Rather than being the hero, swooping in to save the day on those issues, this was then an opportunity for the senior leader to defer to the expertise of the local team and the local leader in solving the problems while providing support as needed. We also needed to make the rounding predictable. It couldn't just be get there when you can. If the rounding wasn't scheduled, it was too easily bumped by other things. In general, each leader committed to round in 2 areas, and those were then scheduled for 30 minutes each every other week. Leaders then periodically rotate to new areas. Originally, it was quarterly, but we recently changed that to a 6-month rotation to provide some more time for building relationships. Because when you think about it, every other week, a quarter goes by pretty quickly. And then finally, for the first couple of rotations, since we already had plenty of other hurdles to overcome, there was careful thought in the pairing of leaders and units. Just as we said that culture is local, and the survey showed that each area had its own unique set of specific needs, each leader is unique as well. So we worked to pair each leader's strengths with where they would be of the greatest benefit. So we kicked off our senior leader rounding at the end of 2019. We were off to a good start, and then COVID hit. In the spring of 2020, we were faced with some hard choices. COVID was raging and the sky was falling. Our daily heads and beds COVID count had skyrocketed to 40. That started people talking about, maybe we should pause this leader rounding. We can't have leaders going into frontline areas. The staff are going to be too busy. We can't have people going in there. We need to limit the risk of spreading COVID. All sorts of things like that. Or maybe instead of stopping, we can do remote rounding. Well, we did our due diligence and looked at the options and luckily decided that no, now is not the time to pause or go remote. Now is the time that our staff need the presence of leaders more than ever. Think of the message we'd be sending if rounding was a leader's face on an iPad saying, hey, I'm here for you. So we doubled down, we kept rounding. We added more leaders, we added more locations. We sat and listened to staff tell us about their concerns, their needs, and yes, their wins. Through COVID, we had wins. Leaders are present to understand, to support, to provide the positivity right when the staff needed it the most. In retrospect, what was a hard decision at the time now seems pretty easy. The sky didn't fall with 40 COVID patients, or when we hit 163, or when we hit 177, or when we hit 273. And I truly believe a large part of that is because the staff knew that no matter how bad COVID got, the organization supported them, and that helped them to bounce back every day. So was it all worth it? Yes, yes, and yes. In our 2021 survey, we added some custom questions specifically related to our leader rounding. We then used those questions to stratify the results in each of the 8 cultural domains. In the top set of graphs, we have our percent positive results. And in the bottom set of graphs, we have how those results rank in the safe and reliable database of hospitals across the country. Orange is respondents who said, no, leader rounding does not occur in my area. Yellow is yes, leader rounding does occur in my area. And green is a subset of the yellow. And it's yes, leader rounding does occur in my work area. And I see feedback from the leaders. Across the board, every single domain shows a clear improvement from no to yes with feedback, both in percent positive and in percentile rank. They're not little changes either. These are jumps from fewer than half the people responding positively to more than 3/4, to questions around communication breakdowns, recovering after setbacks, feeling safe being treated here, and all of this in the middle of COVID. I don't know if anybody noticed on one of the earlier slides, our results during COVID, we improved in every cultural domain. Ranking that performance against Safe and Reliable's score survey database makes it even more obvious. Having a program of consistent, predictable leader presence in the work area is the difference between bottom decile and top decile performance in nearly every domain. I don't know of anything else that can drive such improvement. Oops. Maybe I spoke too soon about not knowing anything else. What about positivity? As part of our leader rounding, we also asked the leaders to focus on the positive, as we've learned from Dr. Sexton. Instead of just asking for a list of everything that's going wrong, ask what's going right. Who should be recognized for doing a great job? We then used a different custom question specifically related to positivity to stratify the results. It should be no surprise that the scores for people who interact with positive leaders are better across all domains than for ones who don't see positive leaders. What is surprising is just how significant the difference is. The bottom first or second percentile compared to the mid 90th percentile. So wrapping up, if we hadn't assessed our culture and well-being with the SCORE survey, Would we still have taken the action to build a program of leader rounding? Maybe, maybe not. What we wouldn't have known, though, is whether or not it was effective and whether or not we were making a difference. When we were designing our leader rounding, we looked at examples from other hospitals, but then designed our own Valley Health program to match our own culture and our own needs. Culture is local and needs are different, whether it's unit, hospital, health system, etc. And any program needs to respect that. And finally, I'll summarize this with just 2 words. If you remember nothing else, remember presence and positivity. And with that, I don't know if Kathy, if we have any questions.
Thank you, Jim. Wonderful presentation. And I don't see any questions right this minute, but we do have a few minutes before we need to wrap up. So would welcome any questions from our participants.
Oh, I see a raised hand from Teresa. How do we? I can't see the chat. Oh, actually I can.
Let's see here. I see, what tool did you use? Donna is asking us about that.
For the rounding or for the assessment? For the assessment, we used the score survey from Safe and Reliable. Interestingly enough, they are one of the sponsors of the summit. And for the rounding, it was something that we had worked with Safe and Reliable initially to design the rounding, but then what we did was we took it in-house and we really built a Valley Health specific rounding program.
I see another question specifically to rounding. Were you rounding to be seen and available, or were you rounding on specific topics or focuses?
Oh, excellent question. And we had a lot of discussion around that as far as, should we, have a specific message that we're trying to communicate. We needed to be that was delicate because we didn't want it to sound scripted, like we're walking around to, just, okay, hey, I'm going to spout this message. Certainly, there are things that can be worked in. But really the main focus was, big ears, big eyes, little mouth, to be present, to talk to the staff, to listen to the staff, to hear what their concerns are, see what questions they have.
Great. Jim, there's also a question around how did you engage all senior leaders to round, and how would you coordinate this in a large health system to make sure all system leaders are included?
Well, really, it was because, this was an organizational priority. Our journey to high reliability, which this was part of, was something that was a board level decision. And both our former CEO and our new CEO for the system made it very clear that this was a priority. I will admit, at the very beginning, we did have some a very few cancellations where, oh, hey, this other meeting came up, I wasn't able to make it. But then, people very quickly, I'll say got on board with it, but it was more than that. It wasn't something that people were doing because we're requiring you to do it, you're being forced to do it. People very quickly saw the benefit of it, and really, from what I've heard from the different leaders, they love doing it. If people are only rounding because they're being forced to do it, you're never going to be successful. It has to be because people want to do it and they enjoy doing it and they see the benefit of doing it.
Great. I think that answered a couple of the questions out there. And then there was also a question about, did rounding encourage learning across the organization? So maybe you could comment a little bit on how you shared some of your learnings outside of rounding.
Oh, okay. Yeah, let's see, number of different ways. There were things that, we would share via our system-wide directors meeting. But then, through our high reliability journey, we also had other ways of sharing information. There's something called a lens board, which is like a digital huddle board, which I won't really go into that. But then we had our whole governance structure for high reliability, where learning at the local level would roll up to our regional governance, up to our system governance.
Great. Could you speak a little bit more about how the whole concept was presented to senior leadership? And you mentioned that it was a priority for your organization towards your journey to high reliability. But if you could speak a little bit further about that and any advice to our participants, that would be great.
Sure. Really, I think one of the most important things was, first understanding the why. Why are we doing this? What problem do we think this is going to solve? You don't just say, hey, let's do leader rounding without having a why. What problem are we trying to fix? And in our 2019 survey, and then in some initial sessions that Safe and Reliable had done interviewing staff, we could see that there was a disconnect, that we needed to really improve the communication between senior leaders and frontline staff, and really improve the engagement there, so that people would be more comfortable seeing senior leaders, rather than there's a senior leader in my area, must mean something bad is going to happen. And then also, really, the ability to understand firsthand what the staff are living through, and some of the challenges.
How about in terms of safety events? There's a great question regarding what you saw in terms of a decrease in safety events or an increase in reporting of near misses or great catches.
That is another good question. Unfortunately, I do not have that data available with me right now. I will have to check on that. I'm sorry.
Let's move on. That's okay. Let's move on, because I know we're getting close on time, but there's another really great question here. So maybe we can just take this one. Have you considered including patient safety staff champions or safety coaches with you while you round as an opportunity for their learning, and what might be the impact on them, leaders and staff? So that's a great idea that I think we all could take back from this presentation. So any comments on safety coaches?
Sure.
Or CUSP teams, if you use the CUSP model, how that might be engaging with your leaders?
Well, and initially, for the first couple of rotations, we did have a facilitator from our quality and patient safety team, which we've done some reorganization lately. So, there's a different name, but, we did have a facilitator going with each of the leaders to, really be that additional set of ears, jotting down notes, and, discussing with the leader afterwards as far as, how it went, so that the leader could focus on the conversation and, still make sure that we were capturing the information. But yeah, as far as, other people going with the leader, yeah, I think that's a great idea. As long as we don't turn it into, a dog and pony show of, okay, here's a gaggle of, 5 or 6 people coming through. You really want that, that personal engagement.
Right, right. How about involvement of physician leaders in your
Oh
rounding
yeah,
process?
yeah. All of our VPMAs, physicians from our board, um, all very involved. I still remember, one of the first times that I was rounding with a neurologist from who is actually one of our board members, and he was rounding in our transfer center and got chatting with the transfer center nurse, and he said, "Hey, I recognize your voice. You're the person that I talk to when I call looking for a bed for my patients." And she said, "Hey, I recognize your voice. You're the person who calls me looking for a bed for his patients." And it was just amazing, the relationship that they developed, because then, time after time as we went back there, just the great conversations that they were having and the genuine interest that he was taking in the work that the transfer center was doing, rather than it just previously it was, okay, hey, I'm going to call some voice on the other end of the phone and say, I need a bed. And that voice on the other end of the phone is going to say, I don't have a bed for you. Now that, he's seeing the work that they're doing, the challenges that they're facing, it's incredible.
Great. We've got time, I think, for one more question that came to the chat. How did you get past some of the staff resistance to participate in the survey? Did you have any baseline data which prompted the rounding?
We didn't have that much deep resistance to taking a survey, apart from, just the usual, not another survey. And, to get off to the worst possible start, the first time we did it, our first survey was within it was within the same month as us doing Press Ganey. Luckily, the next time we did the survey, we split them by about 6 months. But we really didn't have much resistance. We had, each time we do the survey, we get about, roughly about 70% response rate. We try to make it as easy as possible for people to take the survey. Pushing the link to desktops, email, hard copy with a QR code on it. Our VP of nursing at one of our smaller hospitals came up with a great idea that I had wanted to do system-wide, but she went and bought a bunch of Score candy bars and brought those around just to remind everybody, do the Score survey. Here's the QR code for it. I wanted to do that for the whole system, but I was unfortunately not able to get 6,000 Score candy bars on short notice.
Well, we have definitely enjoyed your presentation today, and I think we're going to wrap up now and give our participants the opportunity to have a few minutes so that they can transition to their next breakout session. So thank you again, everyone, for joining this session. And Jim, thank you so much for sharing your experience and expertise.
Oh, thanks, Kathy, and thank you for everybody that dialed in.